My background, and you can see it up here, I was a country GP for 30 years in the North Pennines in Weardale, of rolling hills of heather and sheep. This is a haven of old England, far removed from the madding crowd and politicians, fortunately. Farmers, you wouldn't believe this, they actually counted their sheep in the language of the Vikings. And if you had an infection, a viral infection, it lasted more than 2 weeks, it was invariably glandular fever. In 1987, all that tranquility and relaxation changed for me by two interrelated events. The first one was I was befriended by Dr. John Richardson, a Tyneside GP, whom I have no problems in calling the Sherlock Holmes of clinical medicine. I don't think I was Dr. Watson, I was more a valet and a minder. Nevertheless, he taught me a lot about enteroviruses, and one of his favourite sayings was, "I'm an enteroviral man and an ME fan." Now, I think the next slide has already been partially presented by Dr. Chair, so I'll skip through it pretty quick. I only want to add a little something to it. Enteroviruses do cause single system disease, but they also cause a combination of system disease at one and the same time. And you don't need to tell me to tell you hands, foot and mouth, dermatomyositis. So why shouldn't there be myalgic encephalomyelitis? Cardiovascular system, 20% of our patients who have ME have myocarditis. They affect the glandular system, has been mentioned, the thyroid and the pancreas. They, as Dr. Chia said, they form a persistent enteroviral infection, and this causes a fertile field for autoimmune disease and tumours. He mentioned thyroid tumours. Dr. Richardson had a high incidence of astrocytoma and retroperitoneal carcinoma. I've seen osteochondromas and dentinomas, which are exceptionally rare, but when you consider these viruses affect the mouth, affect the brain, affect the pancreas, affect the thyroid, if they persist, why shouldn't there be a fertile field for tumours in these areas? An important thing which nobody has mentioned yet, the bulk of patients are female between the ages of 20 and 40. So some of them are going to be in their reproductive years. And there's striking fetal abnormalities with enteroviruses. Again, it's not surprising. There's a high incidence of hair, lip and cleft palate when Coxsackie-A is epidemic in the vicinity. Dr. Richardson has shown that in the first trimester, patients who aren't protected by immunoglobulin and the virus goes over the placenta, they have brain defects. Again, that's not surprising. In the latter half of pregnancy, unprotected by immunoglobulin, there are cardiac defects. The second event, and interrelated to the first, was I Met a Boy. Sounds like a Hugh Grant film, doesn't it? He was 12 years of age, from a loving family. He had an older brother, 14, and he was a good scholar, a good athlete, and every daylight hour outside school he spent helping his grandfather on the farm. So he's a very active boy. He developed a non-specific respiratory infection, and which lasted 2 weeks, which wasn't glandular fever, which was a change, an awakening call for me in the Dale. The following 2 weeks, he improved sufficiently that he thought he could go back to school. The first day back at school, he entered in a cross-country run. The second day, he was confined to bed with an exacerbation of all his symptoms and severe myalgia. He went into the local pediatric hospital and then was transferred to the regional pediatric unit. And at the 7th week, the psychiatrist stood at the bottom of the bed without taking any history whatsoever and said, "My boy, you're depressed." He wasn't before, but certainly afterwards, he and his parents were certainly depressed. I would probably use the word oppressed rather than depressed. I like to use the word inertia, lack of energy, to work, play, and recover, and compare that pre-illness to post-illness. I think it's probably the same as your energy index. You know the rest. It's already been mentioned today. This equilibrium, that some turning of the head, the room spins round and you feel nauseated. That's vestibular and labyrinthine apparatus. Paresthesia, the boy had numbness down the right-hand side of his face and tingling in his arms and legs. Sleep disturbance. Dr. Richardson called this owl syndrome. Owl 1 if you're not asleep by 2, owl 2 if you're not asleep by 4, owl 3 if you're not asleep by 6. In other words, turn night into day. The boy was owl 3. Dysautonomia, we've already heard from Julia all about that. Abnormal blood pressure control, heart rate control, and abnormal sweating. The boy had scratchy chest pains. He had, as we've mentioned, sensitivity to light photophobia and blurring of vision. And the sensitivity of sound is called hyperacusis. And actually, when I was in the room with him, we were in an area of low-flying aircraft. A low-flying aircraft, I think it was a Jaguar, went zooming over, and the boys screamed in pain. This is the basis of the John Richardson score chart for ME. It's been validated by VP1, which is the group-specific protein for enteroviruses. The buspirone challenge test, which is a test of measuring prolactin before and after buspirone. And it's a test of a defect in the hypothalamic circuitry. And also validated by SPET scan, brain hyperperfusion scan. Oops. His signs. Well, obviously he was bedridden. I have a bad habit of going down to the waiting room and ushering the patients along the corridor and up to the surgery. And it's the only way you can basically assess the patient's mobility and coordination. I also watch them exiting in the car park and into the car. And that, again, is a habit of mine, because the local working men's club run an evening course for how to con the doctor, and the difference between entering a surgery premises and exiting it would be entirely different. Skin, the boy had a pearlescent grey sweating skin in a warm room. Cardiovascular system, we've already heard about blood pressure. On raising him, he felt faint. Nothing wrong with his respiratory system or his abdomen. Musculoskeletal system, he had wasting of his latissimus dorsi down the back, and he had a slight curved spine. He had tender muscles to palpate with small infarcts, just like little dry peas in his muscles. And he had muscle jitter, gently exercising the muscle. They used to shake. Vision, this is where I get into trouble with the opticians. He had reverse Argyll-Robertson pupils, and that's not supposed to happen. It happened, Argyll-Robertson pupil happened in syphilis, where you didn't constrict to accommodation, but you did constrict to accommodation. You didn't constrict to accommodation, but you did to light, is the reverse of the syphilitic process. And that occurs in ME commonly. He had numbness on his trigeminal 1, 2, and 3 down the right-hand side. Romberg, I couldn't test because he was basically bedridden, but he had a slow nystagmus to the same side as his numbness. I couldn't test for coordination. The pronator sign, nobody does this, but in the old textbooks, if you ask a patient to, hands up, don't shoot, instead of doing that, they'll do that, because they haven't got the pronators and supinators of the arm regulated in the brain. So one constricts and the other relaxes. Motor servo, this is an American term for, I think it was Anthony Komarov. I first heard this term. He had a positive sign when you test left, when you exercise left leg, right arm, and then come and do a tonic test of the last limb you check, you get cogwheeling, which is the same as in Parkinson's. His was positive. His reflexes and planters were normal, but in this disorder you can get cross reflexes. You tap one knee, one patellar tendon, and the opposite knee extends up. You can get that. You can get clonus of reflexes. You can get absent reflexes. You can get positive planters one day, negative the other. There seems to be a fluctuation in all these signs. The sensation fault was in the trigeminal. His posterior columns were intact. The long tracts were intact. Vibration and positional sense were normal. Memory. At the beginning of an examination, I always say just a phrase that would be relevant to the person. In the case of the boy, I said to him, "You remember when I'm finished examining you? Lambs are born in the spring." He couldn't recall that after 10 minutes. Purely simple. This is a conglomeration of tests. Basically, the standard blood tests he'd had were negative. His antibody screen was negative, but in the patients I've seen subsequently, 20% autoantibodies, mainly thyroid. His viral serology, he had high neutralizing titers. His VP1 test, that's the group-selected protein for enteroviruses, was strongly positive. We couldn't get PCRs done in those days, but PCRs basically replaced the VP1 now since Professor Jane Mowbray has retired. His ECG and cardiac enzymes were normal. The scratchy pains that he was getting was a chondritis, I think it's called Tietze syndrome. And there's the Buspyron test. If you want to know about that, Dr. Richardson wrote an excellent article in the Journal of Chronic Fatigue about the Buspyron challenge test involving prolactin and cortisol. The boy had a 400% rise in prolactin level, greater than his brother, who hadn't the illness, after 1 hour after Buspyron. Brain scans, he was too ill to send for them. MRI, I've done about 70, and about 50% of them show unidentified bright objects. And this is inflammatory cells around the end arterioles in the Virchow-Robin spaces. SPET scans, he didn't have a SPET scan, but the SPET scan is about 80% positive in ME patients as compared to an MRI, the brain hyperperfusion scan. The brain actually probably gets a triple hit. One from orthostatic hypertension, we've already heard that mentioned. Two, the cell receptors, ICAMs for enterovirus, Coxsackie B, etc., is in the endothelium, and the endothelium lineage in the end arterioles probably interferes with the transport to and fro across the end arterioles, so that nutrition of neurons is depressed, and therefore the demand to the bloodstream is depressed, and therefore you get hyperperfusion. And I'm not quite sure about the next one. I know Dr. Richardson had suicide patients away, and they were all lit up with VP1 tests on brain tissue. May well have all been in the end arterioles, I don't know, but I assume that the virus can get into the neurons so that they get a triple hit. Now, over the next 2 years since I saw the boy, I looked and searched the other patients within Weardale on the practice list to see if any of them had the same symptoms and signs. And those I found did neutralizing titers, VP1s, antibody screen and pesticide screen. And the VP1s were positive and neutralizing titers were positive, and I laid the graph out together with MS patients. I didn't detect any patients prior to 1979. MS, the spikes in MS are reminiscent of following on after an infectious disease. But you can see the spike in ME. There was 30 patients, twice as many as MS in the practice, and they spiked in 87, and this was sort of the latter half of a pan-endemic of Coxsackie B. And it fit neatly in with Byron-Hyde in Dr. Richardson's graph of onset dates of ME patients. Now, I'll break down the patients, the 30 patients. 8 patients were under the age of 20, around puberty, 10 to 15. And of the 8, 4 were male and 4 were female. 3 were ME alone, pure ME, that's without any other organ involvement. 5 were ME plus 1 had insulin-dependent diabetes, 1 had insulin-dependent diabetes and primary thyroid failure, 1 had primary thyroid failure and a high level of organophosphates. 1, that's the boy, had muscle paresis down his latissimus dorsi, curved spine, and tumours, the chondromas and the dentinomas. And 1 had muscle paresis and organochlorates, and he was a very interesting boy, 10. His VP1 was about 400% above normal, highly positive. And with standard treatment, rest, immunoglobulin, etc., we couldn't move move his VP1 downwards or improve his condition. As soon as we got rid of the organochlorates from his serum by Dr. Richardson's choline and ascorbic acid, the VP1 disappeared over 6 months, became normal, the paresis of his limb muscles resolved, and he was back to normal in 6 months. It's an interesting fact with pesticides as cofactors. 16 patients were between the ages of 20 and 40, 14 female, 2 male, 11 were ME, pure ME, 5 were ME plus, 2 fibromyalgia. And I say this because although they had mild central nervous system problems, they had severe myalgia. And not only that, but they had fibromyalgic nodules the size of pullets' eggs along the sacral nerves. 2 had myocarditis. A further patient had myocarditis plus primary thyroid failure. 6 patients were at puberty, and of the 6, 5 were female and 1 was male. None were ME alone. They were ME with other organ involvement, mainly autoimmune. 1 had connective tissue disorder, so-called CREST, that you get in lupus. She also had pernicious anemia. She now has primary thyroid failure, and she had a high level of lindane. 1 had ME in pancreatitis, 2 had ME in myocarditis, and 2 had ME in primary thyroid failure. And I would only sort of draw one basic point from this, and that is at immune turbulence at puberty and at the menopause, you're more likely to get other organ involvement, particularly autoimmune disease. Now, because Dr. Jason was talking about diagnostic reliability with regards to research, I've held this clinic for 20 years and seen 1,000 new patients. Genuine ME, 75%, of which ME alone, with no other organ involvement, was 30% of the total. Neurosis, 10%. Other infections, which are diseases in their own right, were 10%, including Lyme's, chronic glandular fever, and SMON, which is subacute myelooptic neuropathy due to Melnick virus. And 5% were due to pesticide-delayed chronic neuropathy. So if you don't select your patients correctly, your research is going to be flawed and meaningless for ME. I estimate that the prevalence of ME is 400 per 100,000. I think this compares with Becky Dowsett's. I think she said 500 over 1,000 in her silent epidemic in her children teachers paper. MS in Weardale is 200 per 100,000, so there's twice as many ME patients than MS patients. Sex, female to male ratio 4:1. We know the age groups that occur in. 50% occur between the ages of 20 and 40, and 25% each at puberty and the menopause. Mortality and morbidity is unknown because it hasn't been clearly defined, this disorder. One of the important things is to clearly define this disorder. We know that mortality in enteroviral infections, serious enteroviral infections, is in the order of 5%. Pregnancy. I've already mentioned pregnancy. That unprotected by immunoglobulin and all fetuses were abnormal. This is much the same as rubella. I don't need to mention any of this. It's already been excellently put to you by Dr. Chier. I only want to mention host, range, and transmission, humans, animals, and birds. It's spread by the fecal oral route, hand to mouth, down the sewage works, into the streams, into the rivers, into the estuaries, and you can contact it in any of those locations. But Dr. Richardson, I always smiled when he relayed this story. Seagulls roost in inland reservoirs. And out he went with his rowing boat and large net and trapped some of these seabirds, these seagulls, roosting seagulls, and stuck a swab up the cloaca. I'm sure they didn't like it out there. And took water specimens from the reservoir. They were all positive for enteroviruses. Now, the interesting thing is that enteroviruses aren't destroyed by chlorination. So, down the sewage work, down the stream, down the river, into the estuary, back into the reservoir, back through the tap. It is a perfect water cycle. Again, you've had all the nuts and bolts explained to you, so I won't waste time with that, other than to mention that the restriction of polio on E71 is because of CD155, the surface glycoprotein. That's a docking receptor. And it's mainly found on anterior nerve tissue, the motor systems, i.e. poliomyelitis. And ICAMs are very widely scattered, so you get a large trophism and multi-organ involvement with the other enteroviruses. I don't think I'll get a job with punch or save punch or whatever, but here we are. I'd like to talk a little bit about host-viral interaction before going on to management. From a viral point of view, if the virus is too virulent, it'll kill the host, or it will spread and kill all the hosts before it can, before the immune system attacks it. If it's not, and it'll disappear from nature, there's no hosts left. If it's not virulent enough, then the host immune system will eradicate it and it'll become extinct. From the host perspective, if the immune system action is too weak, then the resulting severe viral dissemination will be lethal. And if it is too strong, then you can get severe immunopathology, which again will destroy organs, which again will be lethal. So the virus is trying to evade the host response and spread to other hosts. And the host immune system is trying to destroy the virus without too much immunopathology. And the longer they interact, the more balanced they become, and they settle down to peaceful coexistence. And this can be seen with many viruses. Herpes virus persist in peaceful coexistence, so-called, although they do cause sporadic illness. And Papavero JC virus can exist in the body all our lives without causing any problems at all. But enteroviruses aren't like that. And if I can draw a parallel with the war in Iraq and Afghanistan, the Allies have sophisticated weaponry, and although the turbulent phase of battle is over, there still occurs incidents of friendly fire, collateral damage, and insurgency. And so it is with enteroviruses, an immune reaction, except it has different names like bystander activation and molecular memory. And in essence, enteroviruses are our insurgents. They're not harmless, persistent viruses. They're our Al-Qaeda, in other words. And ideally, we should come through the turbulent phase of battle, down into the peaceful phase of battle, lock them up and throw away the key and let the interferons, etc., decay them within the cell. But that doesn't happen, does it? Today, it doesn't happen in real life, never mind in host immune terms. What we actually do is leave the cell door open for at least 6 months. We put a psychiatrist as the governor of the prison who tries to pacify the virus with cognitive behavioral therapy. I have never heard so much rubbish in my life. So hello, two flicks. The aims of management are obviously typical prevention, get right away through to peaceful coexistence if you can't eradicate the virus, minimize stresses, because they suppress they enhance steroid production in the body, which suppresses the immune system. And by doing so, you'll close down the fertile field for further organ damage. And this system must be maintained. And that's important with regards to activity. So prevention. Vaccination, there's a lot of controversy over this. But I would dearly like to have a pilot study on vaccination of the VP1 domains and just note the reduction in incidence of severe brain inflammation, myalgic encephalomyelitis, myocarditis, dilated cardiomyopathy, insulin-dependent diabetes, primary thyroid failure, to name a few, just to see what they would drop. I've got 5 minutes. Efficient early warning. At the moment, things are being run down. We've got no viral surveillance. We don't know what's going along. Doctors are like a blind man in a dark room, strange dark room, looking for a light switch. It's atrocious. Isolation, well, you don't need to... it's one of these problems about sort of spreading of illness. Today, the nappied baby, the infant, the under 5, I don't like to use the word, but it's dumped by parents with infective disorders into childcare and into nurseries, so things can spread rapidly. With some viruses, it's fine. It helps the immune system become fighting fit. With others, it's dangerous. Antivirals. As far as I'm aware, there are no efficient antivirals to cure this illness. As we know the pathways, as we know the interferons and the lymphokines, etc., no doubt medical science will come up with an antiviral, hopefully in the non-too-distant future. If I can just come back to persistent virus, activity of the cell is going to produce viral RNA as opposed to capped cell RNA, and rest is more likely to reduce one and improve the cell RNA. Outside the cell, there's a containment of CD8 plus T memory cells who call in the SWAT team if these guys, virus pokes its head out. Stresses reduces that system, and immunoglobulin enhances it both passively and in a modulatory way. So how do I treat a patient? Well, the first thing is obviously early diagnosis, explain management, and if necessary, if a myocarditis is associated with the ME, obviously treatment will be better in hospitals. But the bulk of ME patients can be treated at home. And to rest sick cells as much as possible and to stop viral replication, we draw a baseline of the capabilities of the patient and then gradually increase up from that baseline, establish another one, and go up stepwise. And at any time, that can be stepped back if the patient informs you that they're deteriorating. And activity should be done in a waveform. Do rest. Do rest. Immune regulation with hemoglobin I give subcuvia 5 ml 7 to 10 days for the reasons that I've explained. We've never done any controlled trials on this because we felt it unethical to not give patients this treatment. Stress reduction, right. If it's a child, once they're sort of pottering around the house, why not introduce half an hour of home tuition? If the child's unwell, the tutor can go and have a cup of tea with mother and sit and chat with her. So it's a bit of an ad hoc basis, but build it up, and then home tuition and mixture of school, and then school. And the very last thing that the child will engage in is PE, for obvious reasons. And I've got a patient just like you who went climbing in the Andes. He thought he was 100% fit, back into bed. And the same applies to the adult who goes to work. Therapeutic work, 4 hours, while you're still receiving benefits, incapacity benefit. And then part home, if you're on a computer, and maybe two hours on 3 afternoons, and it's got to be built up flexibly. And the government have got to understand, and employers have got to understand, if they want to get people back to work, this is the way they've got to do it, this paced activity. And benefit payments. At the moment, ME patients are akin to a donkey riding on a donkey in the Grand National. They fall at the first fence. It's a terrible situation. They should be readily available because mortgages, etc., non-payment of life in general is a stress without getting payments. I've already mentioned that pesticides are co-factors in a lot of these illnesses. It's rather ironic. We ban Lindane here, but Monsanto or whoever sell it in the third world and we get it back onto our table through Tesco's. Choline vit C. Choline inputs into neurons and forms the neurotransmitter acetylcholine and neuromuscular transmitter as well. Acetylcholine, the more you put in, the more, in theory, you should make. And I think Edmondson did a paper on this to show that was the case. It's also an integral element in nerve sheaths, and it also mobilizes fat. And anything that's in fat stores, such as pesticides, etc., are excreted in the bloodstream, sulfonated by vitamin C, and you bring them out. In conclusion, Mr. Chairman, I'm sorry if I've gone a little over. ME is a disease caused by enteroviruses, and it is a multi-organ disease. And it ought to be treated by a good, knowledgeable physician. And as far as psychiatry is concerned, I draw an analogy with football. I would award them 1 yellow for foul play, which they've done in the past, another yellow for dissent, which they're continuing to do, and that earns them an automatic red to leave the field of play. Thank you.